can start. Yeah. First of all, Igor, Daniel, thank you very much for inviting me. Of course, it would be much better to be with you now in Kazan, but unfortunately, as you all know, it was not possible. Still, I think this is a great meeting you're organizing, and I think it's very important that we come together and share our experiences. Also, I will not keep you too long because we are already in the coffee break, and I'm afraid you have to listen to me again after the coffee break. As you actually can see, we organized also a VA ECMO course in September, and you can see behind here the coronavirus, which was always with us, but we kept our hygiene rules, so everything went well and our course actually went well. I believe the situation in Germany is a little bit different to many other countries. One of the reasons is that we never got overwhelmed. The health system was still able to cope with all the infections. And I want to go into a few points why I believe which might have influenced this rather positive course in Germany. The first I want to talk about is the Robert Koch Institute. Second, then we go into the DV ICU registry. I want to show you a little bit about outcomes in Germany, briefly mention the European Survey Initiative, and then just the last 2 or 3 slides about our experience here in Regensburg. First, what is the importance of the Robert Koch Institute? It's actually Germany's public health institute, and I believe you probably have the same in Russia. And all public health institutes have the mission to protect and improve the health of the population. So the Robert Koch Institute, which is actually named after Robert Koch, who was the discoverer of the tuberculosis, is responsible in Germany for all the healthcare businesses, and it works in very close cooperation with hospitals and associations. For example, the German Intensive Care Association is in close cooperation with the Robert Koch Institute, and it gives out a daily report. You see one here. For example, you can see the distribution of cases over time. We get these reports every day. You see in blue the onset of symptoms, of course, March, April, many. At the moment, we increase the numbers, and you see all the date of reporting. But we have not such a steep increase as you have seen in many countries. Mortality at the moment is not very high, and not very many patients come to ICU. Why is that? We think it may be related to the demographic distribution. You can see in the beginning there were many very old patients. At the moment we have more younger patients. It seems to change a little bit. The older population gets increasing infections again. And what we also get, we get a 7-day COVID activity for all the rural districts. So we can actually see every day what is the situation. Like up here, you see Regensburg, we are not too bad at the moment. In Berlin, it's increasing. There is one rural district in Bavaria where it is above 50 per 100,000. And this is actually when we do a local close down. A second thing, I think, which is different in Germany, we have many, many hospitals, and we have many intensive care unit beds. For example, you see here a comparison recently published in Intensive Care Medicine, comparison of intensive care unit beds in 14 European countries. And actually Germany has by far the highest number of intensive care beds. Like compared to England, they have around 4,000, and in Germany we are almost up to 30,000 beds. And there is a very short time to the closest hospital, a very short travel time. So on average, we travel 9.3 minutes to the next hospital. And there is, they actually developed an accessibility index, and the average accessibility index was in many, many regions of Germany is very high. You see in Germany, almost all regions are in green. That means you can easily access a hospital in a short time. Quite different actually in France or in England, and of course in Sweden. Up here there are hardly any intensive care units. I think a very important intervention was the DV-ICU registry. This was done in cooperation between the Robert Koch Institute and the German Interdisciplinary Association for Intensive Care and Emergency Medicine. And actually every hospital has to report every day the COVID cases and the ICU capacities. This has been made mandatory by law since April 2020. If you do not report, you get less money. So at the time being, 1,285 hospitals report every day their number of COVID cases and their free beds. As I told you, there are roughly 30,000 ICU beds, and actually 186 hospitals provide ECMO in Germany. It's the first time we know this number. Before, nobody knew how many hospitals do ECMO, but it's close to 200 hospitals. Like you see down here, summary report of end of September. I've translated it into English. So you have here the COVID-19 case numbers currently in ICU. We have 352 cases in intensive care unit all over Germany. Of those, 195 are ventilated. You see the changes to the day before. And you see here down here the total cases. So we have 17,536 cases in ICU in total. 4,196 died in total. This is only patients who had been in ICU. And then every hospital has to report ICU capacities, so you can distribute actually patients to different hospitals. Currently occupied, you see the numbers down here for low care and high care and for ECMO. So at the moment, there are 138 ECMOs running in Germany. This is not COVID, it's ECMO in general. And you see down here, currently free, we have 7,200 high care ICU beds currently free, and we have 608 ECMOs free. Interesting, every hospital has to provide a 7-day emergency reserve of ICU beds. So within 7 days, we could actually increase the number of ICU beds for another 12,000 beds. I think this has been very important for the development in Germany. So we have very close control over the beds and know quite well how many beds are occupied. You see it here as a geographic distribution. The percentage of COVIDs of total ICU beds per country. We have at the moment very little numbers. So most ICU beds are actually occupied by other patients. For example, in Bavaria, we have 1.3% of ICU beds now covered by COVID. In Berlin, 2.5%. It's going up in Berlin at the moment. This can be broken down into local or rural districts. Regensburg is down here. So we have at the moment, we have 4 patients with COVID in our hospital. But overall, the situation is still blue in Germany. It's not very much. We have still a high number, which you see on this map, of free beds distributed to the different countries in Germany. What is the outcome? This was recently published in The Lancet from Christian Karagianidis from Cologne. He actually looked into 10,000 patients who had been hospitalized in 920 hospitals with COVID-19. He took the data from the German local healthcare funds, the AOK. You get true data there because all hospitals report because they get the money from the insurance companies. And these had been patients between February 26 and April 19. Of these 10,000 patients, 1,727, 17% were ventilated, and 119, 1.2% were on ECMO. When you look at age and comorbidities, up here age, patients without ventilation, patients with ventilation, you can clearly see there is a high number of very old patients. Here is 75 years of age, actually the highest number of patients without ventilation and also with ventilation were above 75 years of age. I think this is different to other countries. Also, the older population was ventilated in Germany. And those who were ventilated actually had a higher comorbidity index. So there were many patients, 13.6%, for example, in the ventilated group, had a Charlson comorbidity index above 5. So they're quite sick and were still ventilated. What was the in-hospital mortality of these patients according first to age and second whether they were ventilated or not? Let's look at this first here. These are patients without ventilations, 8,200 patients. And you see clearly, which is known to all of you, mortality increases with age. So if patients were more than 80 years of age, they had a mortality of 34% without ventilation. If they were on ventilation above 80 or even above 70 years of age, mortality was very, very high. The overall mortality was 22%. Those who had no ventilation, on average 16%. Those who were on mechanical ventilation, on average 53% mortality. Partly related to the high number of very old patients who had been ventilated. And here you see the graph over time. It was actually quite difficult to find out what was mortality on ECMO. This has been given in the supplement. Overall, I told you there were 119 patients in these 2 months on ECMO. Actually, of those, 11% were older than 70 years, which, for example, in Regensburg had been contraindication for ECMO. And when you look into mortality, down here in the supplement, patients with ECMO, 70.6% actually died in hospital. So mortality on ECMO in this unselected cohort of patients with COVID in Germany was quite high. You have already heard about this survey, the European survey, which was initiated by Roberto Lorusso in cooperation with the EuroELSO. And actually, I am very, very happy that we are able to do this survey. And I'm even more happy that we have so many centers from Russia taking part. To my knowledge, it's actually the first time we have such a survey for Europe, including Russia, including Turkey, which is partly European, and also Israel is in it. So we have 24 countries. This is actually going to be published soon now in Intensive Care Medicine. And most of you probably will be aware of these data. This is the European trend over time. In the beginning, there were not many centers reporting, but you see a steep increase in the number of ECMO in all of Europe. In these centers, I think 170 centers at the moment are reporting. And then you see it's leveling out. The numbers are not really increasing for the last weeks and months. Like in the last week, we had an increase of only 15 ECMOs in these 177 centers. So at the moment, it seems it's rather quiet in Europe. We don't fully understand why. The numbers are going up, and we will see whether the number of ECMO goes up as well. I think they show us quite good numbers. What is the expected survival? So from this survey, all of Europe, we have 854 patients from this. Let's go back. 1,556 patients in total on ECMO. 854 are successfully weaned, which is 55%. A few die after weaning down here, and there is quite a big number of patients dying on ECMO. So at the moment, deceased on ECMO after ECMO 44%, ongoing 5%. So I would say the expected survival is probably 50 to 55% of this cohort. There is a long distance between Kazan and Regensburg. Regensburg is a rather small city down here, close to Munich. And at the last part of my presentation, I want to go briefly into our experience, what we have done here in Regensburg. We had overall 64 COVID-19 patients in the intensive care unit. The maximum was on the 10th of April. There we had at one day 43 patients in ICU, 36 ventilated. And overall, we had 25 COVID-19 patients on ECMO. All of those had been transported to our hospital. In Regensburg, we had only a little COVID, but we have a close network. So all these patients, or most of these patients, were actually transported from other hospitals to Regensburg. What was the outcome of these patients? Well, we have done 20 VV ECMO cases. Of those, 65% were weaned, 60% were discharged, 30% died, 10% are ongoing. And we had 5 patients on VA ECMO. Of those, only 40% had been weaned. That is 2 patients. Those have been discharged. So there are patients on VA ECMO with COVID who survive. And 3 of these 5 died. What have been our observations? Daniel, you asked, is there a difference between COVID patients and other patients on ECMO? Yes, I think there are differences which we have not fully understood yet. But these are just observations. One is There is early the combination of, on one side, pulmonary hyperperfusion and shunting in the lung, and second, we have already in the beginning the local thrombotic occlusion of small vessels, which sometimes leads to right heart failure and increased pulmonary hypertension. We have seen in some patients excessive hypercoagulopathy in the beginning. That is why we early switched to a more pronounced anticoagulation in our COVID patients. Normally, we would run VV ECMO patients with an APTT of 50. COVID patients, we aimed at an APTT average of 60 seconds, and we added very early 50 milligram of aspirin per day. We have not proven whether it helps, but we got the impression that, for example, we have less acute oxygenated thrombosis. There is a significant risk for pulmonary embolism in these patients, so we do a CT scan in all. After they have been put on ECMO, all of those patients are brought to the CT scan, and they always get total CT from head down to the groin. We found a very high risk for ventilator-induced injury. Therefore, we really aim at ultra-protective ventilation in these patients. Very small tidal volumes, very low driving pressures. Our impression is these lungs are very much prone to really ventilator-induced lung injury. In the beginning, as you know, there is a good lung compliance, which is different to many ARDS patients, but late we see stiff lungs, which are quite similar to the typical late ARDS. It seems that proning on ECMO is helpful to decrease aggressiveness of ventilation, so we do proning on ECMO. There is a significant risk of right heart failure, especially with aggressive ventilation. In these patients, we have used a lot of inhalative vasodilators, and when we see that the right ventricle is on strain, we lower PEEP. There is the risk for this hyperinflammatory syndrome, which I think we haven't fully understood. It's called hyperinflammatory syndrome, but if I compare, for example, interleukin-6 levels in COVID patients to interleukin-6 levels in somebody who is in severe septic shock, COVID has always lower inflammatory mediators than somebody in severe sepsis. So I have seen far worse inflammatory syndromes in sepsis compared to COVID. And I think there is something going on we have not fully understood. Some patients develop cardiomyopathy. Others develop massive vasoplegia, and you cannot keep up blood pressure. We do regular check of ferritin. Every second day we check the ferritin. When we see an increase of ferritin, we are considering the secondary hemophagocytosis syndrome. We would do in these patients bone marrow biopsy to rule out hemophagocytosis, and we would start these patients on anakinra early. Anecdotally, we have seen that plasma exchange seems to help. We are all talking about filtration of these cytokines. My experience is that cytosorb is not very effective, and we have seen several patients now who went into this massive vasoplegia and poor cardiac output. We actually do plasma exchange in these patients now if we see a chance to help them. There is always a risk that this is actually not hyperinflammatory syndrome, but it may be systemic fungal infection. We have seen in post-mortems actually invasive fungal infections in quite a few, aspergillosis and also candida and psychomycetes. So systemic fungal infection, I think, is a high risk in these patients with COVID in the later course. Courses have been very prolonged. I show you in the second presentation a few patients. Weaning is difficult, as you all know, and our feeling was that there is a profound immune paralysis in these patients, and they are very much prone to secondary infections, like fungal, I told already, but it may also be viral. When they survive, they have severe critical illness, myopathy and neuropathy, and it takes them a very long time to come back to normal. To sum up, I think in these patients it's very important to be patient, take your time, do not give up, and then you hopefully will save some of them. Thank you very much.
Thomas, danke schön for your very interesting lecture. And before questions from the audience, I would like to ask you, what do you think? What so big difference between Germany result, in all Germany result, 70% mortality, and the result from Regensburg, it's 60% to discharge. What's the main reason for this?
I think, first of all, we are a center with a lot of experience. So when we do around 200 cases on ECMO every year. So we are quite used to complications, and these patients actually are prone to complications. The second thing is that we have been quite restrictive in the beginning with inclusion. We had 65 years of age as the upper age limit. We were reluctant in doing multi-organ failure and severe comorbidities. I think that's a difference to other hospitals in Germany. And we didn't give up. Our longest run was 72 days, and he actually came off ECMO in the end, even if you don't see an improvement for 4 weeks. Many of these patients who seem to be severely fibrotic, in the end, still the lung opened up. So we just waited. We were never overwhelmed, so we were able to take care of all patients. We had sufficient nursing. I think it was a multitude of reasons.
Okay, thank you. And some questions from the audience. Yes, please.
Thank you so much. We all know that prone positioning improves the results very much, but there are patients in severe situations when it is not possible. In your center, what will be the situation when you will say that prone positioning is not an option for the patient?
Okay. I think, first of all, of course, you need an ICU staff which is very much used to proning patients in general. You should not start proning when you're not used to it, because, of course, there is a risk that you might lose a cannula and then your patient is dead. So when would we not prone? I would not prone when they are on high doses of vasopressors. We would be reluctant. I would, of course, be reluctant if they have any form of liver insufficiency, if they have abdominal compartment, things like that. We would not prone. We would not prone obese patients, very obese patients, because it is too difficult to bring them back when you have trouble.
Thank you, Thomas, again. And now we will have interruption for coffee break, 10 minutes, and after that, you next.
You?
Thomas, do you hear us?
Yes, I hear you.
Yes. Now we have coffee break, 10 minutes. Okay.
Great. After the coffee break, shall I continue or will Axel continue?
Yeah. Do you hear us?
Yes.
Yes, it's good. We
hear me?
hear you and we see you. And we have time shift, 30 minutes, sorry for this, we've got technical problems. And you will speak after Thomas' lecture, okay?
Dear Thomas, can I ask one question?
You can.
When you make the tracheostomy in these patients?
Well, late.
Late.
Late. First of all, there's as long as they are positive and we have still virus, we are reluctant, because during tracheostomy, there definitely is a risk that you get infected. So we generally waited until they were negative. We did not have virus anymore. So that has often been day 20, day 25.
Okay.
But in general, we were reluctant to do tracheostomy. Called in.
Can you make it surgically?
We called the ENT surgeons these patients. Yeah, we actually had a rule in the hospital that ENT surgeons have to do it. We were not allowed to do it.
Percutaneously, no.
They may do it percutaneously, yes, but it was always done by ENT surgeons.
Okay.
It was a rule in the hospital.
You.
If they get infected, it's not so difficult.
I'm sorry, Dr. Axel, do you hear me?
Yes, I do. So I'm sorry, we have now coffee break. It will be during next 10 minutes, and after that, Thomas Muller 20 minutes presentation.
I'm
And after
happy.
that, you
I'm happy with the coffee break.
It will be about 30 minutes for your presentation. Okay? I'm
From
sorry.
now?
Yeah. Okay. Thanks again.
Okay, see you later.
Guten Tag, Herr Müller.
Guten Tag.
Haben Sie die Patienten von Nachbarländern? Und haben Sie die schweren Patienten, wie kommen Sie zu euch?
Ja, in English or in German? How should I respond?
Ja, Deutsch bitte.
Deutsch, ja. Ja, wir hatten 3 Patienten aus Italien, per Flugzeug von Italien nach Nürnberg an den dortigen Flughafen, von dort dann mit Krankenwagen gebracht, alle aber nicht an ECMO. Ansonsten, wenn wir Patienten aus anderen Krankenhäusern holen, dann in der Regel mit Hubschrauber. Anfangs schwierig, ja, weil Hubschrauber der Pilot nicht transportieren wollte. Im Verlauf dann aber sind die Patienten per Hubschrauber transportiert worden.
Ja, danke.
Gerne.
Guten Tag noch.
Danke, Ihnen auch.
Спасибо.